Recording. Good afternoon, everybody. Thank you so much for joining this very important session of Nurses 2 in 3 with Hannah Cadogan. I hope I got it right. Today's topic will be on understanding trauma for our patients and ourselves. So Hannah, who has lived experience, will be exploring the different elements of trauma in terms of both how trauma can affect our patients and reactions and triggers. So I'm going to pass it on to Hannah as we don't have much time. Hannah, over to you.
Hello, hi everybody. Thank you so much for that introduction. My name is Hannah Cadogan and I am the representative for lived experience at the Royal College of Nursing. And the reason for that is because I have my own history with serious mental illness. But I also do work as a nurse. So I work as a palliative care nurse I'm just wondering if I've got the right slideshow up, actually. I think I do. And so I'm a palliative care nurse at a hospice in London. And this is understanding trauma for ourselves and our patients. So this image actually that I've got on here is actually a drawing that I did myself to sort of describe my own kind of trauma. But before I completely start, we are talking about trauma, and because of that, it can actually be a really difficult subject. So I really want to sort of make sure that everybody kind of knows that it's fine to step out of this session, it's fine to come back in again. Please leave if you feel you need to, and please do find somebody that you feel safe with to be able to discuss any concerns that this might have brought up for you. In addition, Doctors in Distress actually hold a weekly support session every Wednesday. And so if there isn't any way that you feel safe to kind of share, and if this was something particularly that triggered you or anything else in terms of any support that you might need in terms of our roles as nurses, please feel free to join this confidential session that is professionally facilitated. So I do really want to say that, and please really do look after yourself, because we will be talking about things that are very difficult. So the aims of today's session is to look at what the definition of trauma is, to explore the different types of trauma, and then there's going to be a brief kind of overview of adverse childhood experiences, understanding the principles of trauma-informed care, because there is a kind of model that has been created, some of you might know that, which is called trauma-informed care, and it's a way of that we can look after our patients. As part of that trauma-informed care model is something that is called vicarious trauma. So we're going to look into vicarious trauma and then what might then help with vicarious trauma. So I'm going to start with the definition of trauma. So I looked it up in the Oxford Dictionary, and these are the descriptions I got. So it's an unpleasant experience that makes you upset or anxious. Now, what I found was quite interesting is when I did actually look at this up, there's actually two different definitions for psychology and medical. So I thought this was quite interesting. So for medical, it's a physical injury. That's why we have things like trauma centres. And then the psychological is actually the mental condition that's caused by a severe shock or harmful effects that last a long time. So there's these two different definitions. So when I saw that, I was a bit curious, and I'm one of these people that likes to sort of look up the sort of origin of words. So then I was like, well, where does it actually come from? And interestingly, it comes from the Greek, which just means wound. So that's why we have this idea of medical, which is a physical injury, as well as this psychological kind of wound. And so that actually made me think of Vincent van Gogh. Because Vincent van Gogh, as many of you may know, was an artist. He was a 19th century artist. And he's very famous for his sunflowers. Most people kind of know that kind of image. But he also did many kind of self-portraits. And I think, again, this is probably one of his most famous self-portraits, where he had actually cut off his own ear. And as we can see, the ear has actually been bandaged, which often for us as nurses, you know, we will do kind of wound dressings and, you know, and probably more than they would have known in those days, all the different various kind of dressings that we have nowadays. I'm sure they wouldn't have had those, but this sort of thing of, we kind of know what to do with that wound. You know, we know how to dress it. We know that we need to keep it clean. We know how to kind of look after it. But the wound that is unseen in this picture is the psychological wound of why Vincent van Gogh cut off his own ear. And I think that is the wound that can be then really difficult. We don't really know to this day. In fact, Van Gogh, at the point where he cut off his own ear, may not have known himself why he did that. And we can make assumptions or think about or make educated guesses why he did it, but actually none of us really know, because he may not have known, and it's not written down why he did. What we do know is that sadly he did take his own life. And as somebody who has actually tried to take my own life, sadly, did survive, I think at that point I didn't really know what the deep wound inside me, what was causing and why I felt like that. And I think this can be the very difficult part of psychological trauma, that we don't always know. Sometimes we're just feeling the feelings of it. And so this, I quite like this definition about trauma, is really showing that it's pervasive, and the fact that it can affect all of somebody's life. It can have lasting effects on somebody's life, and it affects both their physical well-being, their social well-being, the emotional and spiritual. And we often think of that kind of holistic care when we're nurses. You know, we're thinking about all of these different aspects. And the reality is that when somebody has a very deep psychological trauma, all of these parts are actually impacted by that trauma. And that can then make it extraordinarily complex when we're actually looking after our patients. And so I decided to have a look to see about sort of types of trauma. And I actually found this. This is actually a Canadian sort of organisation, which is called Your Experience Matters. And this was what they did in 2016. And I kind of like it because it kind of breaks it down of the different types of traumas. Now, I'm not sure this is inclusive of everything, but I thought these 7 traumas were quite helpful in us understanding the different types of traumas that exist. So we have acute trauma. So that, for instance, is like a car accident, and that can affect people in different ways. So that some people might recover from that very quickly. Some people not at all. You know, they might have long physical effects of that. And some people might then have psychological things that come from that, but it's a one-off event that can affect people in different ways. And anything that happens to somebody, you know, you might have somebody who breaks their leg. For one person, that might mean being off work for a bit, but actually they recover and they're okay and they have good social support around them. For somebody else, breaking their leg might be the end of their rugby career. So the actual effects of a one-off trauma can be very different from one person to another. Then we have what we call repetitive trauma, which is where a trauma is not just a one-off event, it's repeated again and again and again. And there's actually a link between repetitive trauma and complex trauma, and I'll go into that. And one of the examples of repetitive trauma is this thing of just having treatment again and again. Somebody who might be on chemotherapy. Every time they have the treatment, they get very sick and nauseous, and they get very sort of not wanting to go into hospital, not wanting those things to happen because actually it's connected with sickness, or it's connected with, you know, somebody who's got breathing difficulties. You know, it's connected with the fact that they, you know, hospital means that they can't breathe properly, and it creates this sort of repetitive trauma that we can see. And then we have complex trauma, which is repetitive, but it's also more kind of psychological. It's more of this sort of chipping away at somebody's self-esteem. So one of the examples is like domestic abuse. So it's a chipping away at somebody's sense of self, their kind of their self-worth, and people won't even see it. And it can then be very complex because it can be unseen, or it can be complex because somebody doesn't want to leave somebody who's actually abusing them because of the security of being with somebody. So it becomes quite a kind of, it's a lot of layers to it. And so the fourth one is developmental trauma. So this is where we're then looking at children who have adverse childhood experiences. And again, what we're knowing, so there is some research in this, but not a great deal. But what is it beginning to notice is that with children, what's quite different from adults is the brain is still developing. So when you have a brain that's still developing, the complexity of trauma on that brain is kind of more complex because children won't necessarily understand that they're actually having traumatic experiences. And so we're beginning to realize this is actually quite a complex area. And I often hear people say children are very resilient, but actually what you see is that children will be resilient within inside their childhood, but often some of the difficulties will then come out into their adulthood. And actually they will have huge problems as they go into adulthood. So I'm going to just look at this a little bit more. So I know we've still got 5, 6, and 7 types of trauma, but I just wanted to go into adverse childhood experience a little bit more, because this was developed before the sort of trauma-informed care model. And it was actually recognised by a doctor who worked in an obesity clinic in America, who was realising there was a correlation between people having adverse childhood experiences and actually being part of his clinic as adults. And so this is where they began to look at it. And this is from the Centre, which is why it's spelled slightly different, for Disease and Control and Prevention from America. And this was done in 2020. And they sort of put down that from their understanding of some of the research that they had done, these were some of the adverse childhood experiences that people could have. And so you have the ones that is the abuse, so physical, emotional, and sexual. Sexual can actually be very complex because sometimes children don't understand what's happening for them. And I've certainly met people who thought that they were privileged because they were getting more attention until they actually went into adulthood and realised that this attention wasn't about them at all. And so it can be quite late until people talk about something like that. So that's enormously complex for that, like I was saying, that developing brain. You've then got, again, which can often be unseen, is the neglect. So you will have physical neglect. That's often more obvious, more noticed, but then there will be the emotional neglect, which is often not so seen. And you can have, families that's not noticed at all. And then they know that there's specific things within inside a household that can cause adverse childhood experiences for children. So having parents who've got mental illness, seeing, so not having violence put on them, but seeing violence. So if you have got, one spouse who's violent towards another, that will impact the child. Substance misuse, an incarcerated relative. So again, there was actually an article actually on the BBC talking about this, where grown-up children who had a parent as a child incarcerated, about how difficult that is, and the shame and all the things that can go around having a parent in prison, and the lack of that support as well of that parent. And then divorce. So we know that this can cause real difficulty sometimes in sometimes the security for a child. Now, I think what's really important to remember, and particularly about this divorce element, where sometimes that can't be helped, is that just because a child might have adverse childhood experiences does not mean necessarily that they're going to go on and have difficulties. Actually, if that's supported at the time, that they can be okay. And it's often around that support that's given. And that's why some things like an emotional neglect can actually have more of an impact because actually what we know is the social support is very important, that we can't wrap our children up in cotton wool. They're going to have challenges and difficulties. But if people are supported with those, they're generally okay. If they're not supported with them, it can cause difficulties. Also, what is known in the research is that if you have 4 or more of these, you're more likely to struggle in adulthood. And this is then the impact that happens. So again, this was done by the Centre for Disease Control and Prevention, which has created this pyramid, that what they saw was that if you had adverse childhood experience, you then had this disruption in your neurodevelopment. And then you had this, it can then affect the social, emotional and cognitive impairment. So what we find is that people can find it really difficult sometimes to then build relationships and build that social support. People can feel very insecure within themselves. They can have attachment difficulties. This can be very difficult psychological. So people will then be, to try and not think about it because it's so painful, people can then go to quite risky behaviors. They can go to taking drugs. They may not eat properly sometimes. They may then drink alcohol. This can then lead to disease and disability, and what we know is early death. And one of the things that's not widely known so much, so we now know that 1 in 4 people can, have depression. But what's not widely known so much is that people with serious mental illness actually die 15 to 20 years before the rest of the population. And this might actually be some of the cause of why that happens. But what's also interesting as well is that this doesn't start with somebody just being born. Okay, so this triangle is actually a little bit bigger than that. And it actually starts with the social conditions that we live in. So what we know is that people in kind of sort of backgrounds that are poorer, where there's poverty, that can actually lead to adverse childhood experience. And then we have what we call historical trauma as well. So you can have things like war, which actually will pass down the generations. So this is not from any research. This is my own kind of thinking. My grandfather was he was a prisoner of war for 5 years. That actually damaged him immensely. And he struggled then, I think, to give emotional care to my mum, which potentially then meant that she didn't have the skills to give the emotional care to me. So it can pass down the kind of generations. And that's the effect of this sort of like bigger, wider historical trauma. So that actually goes on to the other types of trauma that exist. So you have intergenerational trauma, so parental trauma that passes down to children, and then the actual trauma that happens in a kind of wider sort of society, things like war, genocide, slavery. And so these things can actually go down the generations. And there's actually a really interesting lecture that was done by a lady called Anna Kabusi, who's a mental health nurse, the Skillen lecture that actually talks about racial trauma. And it's done really well. So if you are interested in that, you can look her up and look up the Skillen lecture from, I think it was 2023. And then what I wanted to get onto more so was vicarious trauma. So this is the trauma which absolutely sits in the trauma-informed care model, is actually the trauma that we take on as healthcare professionals. That is trauma that belongs to our patients, but actually we take on. So I am going to carry on talking about vicarious trauma a little bit later on. I just wanted to just share the trauma-informed care model in the sense that all of this very much goes into this way of working. And the important thing to understand about the trauma-informed care model is it isn't necessarily opening up somebody's trauma. So if you look at the last bit of this description, the intention of trauma-informed care is not to treat symptoms or issues related. Now, there may be some of you on this call who are mental health nurses, and absolutely part of your role might be that you have people that are telling you about their trauma, because actually mental health nurses are trained to understand that psychological stress. Some of us who are kind of more physical healthcare nurses, it wouldn't be opening up somebody's trauma. Somebody might tell us, but we don't want to open it up because we don't know if you open up somebody's trauma. Actually, you have to be very careful. All the mental health nurses here will know you have to be very careful about how you then hold and care for that person, because actually they will have protective mechanisms to try and help survive life with the trauma that they have. So we have to be very careful when we open up people's traumas experiences. But what the trauma-informed care model is about understanding that trauma is much more pervasive in our society than we may think, and that many people will have different types of trauma. And actually, sometimes the way that we care for people might re-traumatize somebody. And actually how we are sensitive for the fact that actually, because the reason somebody is struggling, or they might be struggling to come to appointments, is actually because there's a level of trauma there. So how do we have a sensitivity, understanding that there might be trauma, even though we don't know exactly what that trauma might be? So it's realizing or recognizing that might exist there for somebody. And this, I'm not going to share this because I know that when you do these webinars, this goes horribly, horribly wrong. When you try and share, like when you actually try and play videos, normally when I'm in the classroom, I do share this video. And it was actually done by NHS Scotland. So there's some lovely accents, the Scottish accents, but it's actually a really good video and animation that really does explain trauma-informed practice. And if there's any of your colleagues who are interested about this webinar, or anybody you want to, or even yourselves to understand trauma-informed practice, watch this video because it is really good. It does really explain it. Again, though, make sure that you watch it when you're feeling kind of okay, because it does bring up difficult subjects, but I would recommend it. And then these are the 6 principles of trauma-informed care. And the one thing that I want to pick out, because I really want us to go on to vicarious trauma, is the fact that the actual model itself does very much recognise that this is not just patients. This is also staff. So right at the start, the first one, safety. Throughout the organisation, patients and staff feel physically and psychologically safe. So this is actually just about us as humans, how we ensure that our places of work are actually safe for everybody. And sometimes they're not always safe for staff. Sometimes they're actually safe for our patients, but they're not safe for our staff. So it's very much thinking about all of us, not just our patients, because the reality is we're not just nurses. We're also humans as well. And so I'm going to go on back onto that vicarious trauma that we were talking, that was number 7. And vicarious actually means, I don't know whether it's a helpful term really, because I was like, what is vicarious? And then I saw the vicar bit and I was like, my goodness, what is this word? It wasn't a word that was in my vocabulary, certainly before I did trauma-informed care. But actually what it means is the experienced in the imagination through the feelings or actions of another person. So it's the fact of us kind of hearing somebody's trauma and actually really like, oh my goodness, that must be so difficult. We feel it. We feel the emotions of it. We, you know, the painfulness of it as somebody's telling us their trauma, or we're seeing their trauma. And actually that then sits with us. But actually, I think it's wider than just us taking on trauma from others, which happens massively within inside the kind of healthcare system. And this was kind of like my reflection really was, can vicarious trauma sometimes remind us of our own or bring up our own? And the reason I share this is because this is exactly, I think, what happened for me. So I was working as a nurse. I had my perfect job, a job that I had actually had really wanted. I was working on a ward in HIV at Chelsea and Westminster Hospital. And I was really excited about work for this ward. And I was a very lucky nurse. I was in an incredibly supportive team, because people have often asked me, "Oh, Hannah, do you think your mental illness was because of the nursing?" But I was actually in an incredibly amazing team that were very supportive. But without any of us realizing, or me properly realizing, what actually happened was that in terms of looking after people where there was a lot of grief, there were people sort of dying very young, without realizing it actually tapped into my grief, which I had not dealt with. So my own personal grief from my own childhood. And I was kind of having these feelings that I didn't fully understand. I didn't know what was going on. I didn't know where they were coming from. I thought it was because I was taking on these emotions of my patients, which I was, but they were also filtering into my own trauma that I had not looked at all, that I had basically buried. And the way that was coming up was these feelings, these very difficult kind of, I suppose, grief feelings that I didn't really understand. And I think that's the fact that we have our own trauma, and that actually sometimes the patients that can be the hardest to work with are in fact the patients that trigger in us our own pain and trauma. And that is most definitely what happened to me. And I think particularly, I mean, I don't know if we've got mental health nurses here. I think particularly in mental health, it can be particularly hard, this. I think one of the most places that I actually witnessed the most trauma I've ever witnessed was actually in a mental health unit. And I think mental health nurses are really having to sit with really difficult trauma that is very difficult to explain, a lot of that complex trauma. And I think that's often not really understood about the role for mental health nurses. And I think that's very tough. I think we can sometimes see it more easily in some other areas, like with A&E, where we realize that, you know, you're seeing trauma and you're seeing some of these, you know, horrible things that people go through, you know, coming through that kind of thing. But actually, I think the sort of subtlety of some of the traumas that come through into the mental health setting isn't seen so much. So and can really tap into some of things that have happened for us. So I think this is very difficult, and I would love it when, you know, I've got through this to really have a really good discussion maybe about that, if people feel like they feel able to share, because I think that's really important. And so in this kind of way of realizing that as healthcare professionals, we can often take on trauma, we have our own trauma. How do we have compassion for each other? Because what will impact one person might not impact another one. So what I've noticed at work is that working in a hospice, there's certain patients that we look after that will impact nurses, and then there's certain patients that we'll look after that might impact me or somebody else. Because actually what can happen is, because of our own life experiences, that different people will impact us. And I suppose it's that thing of, how do we have compassion for each other, for where our trauma lies, or what things can impact us that might not have actually impacted another colleague, and how we have compassion for ourselves. And the thing that I love about compassion is, I mean, there's so many definitions of compassion, and as you already know, I really like this whole origin of a word. And compassion, very simply in the Latin, is from compati, which means to suffer with. Compassion isn't about making it okay, taking it away, kind of like, you know, giving good suggestions about what to do. Compassion is purely just acknowledging somebody else's trauma, you know, acknowledging that somebody else is suffering, and trying to just be beside that person. How we support each other when there is a patient that might have impacted us. And I remember this with a patient that I was looking after who did with me. And And it was quite complex in my own mind. She was a lady who had actually lost her son 25 years before, her only son, through suicide. And she was now dying, and there was those 25 years had been really, really tough for her. And we realised that she had deteriorated overnight. So we moved her into a side room. We rang her nieces and they were on their way. And for some reason, I just didn't want this lady to not be with somebody if she died. I was really worried that we were worried she might die before her nieces came. And I sat in the room and I held her hand. And I remember my lovely manager at the time walking past, and she just looked at me and she knew that it was really important. I had, I think, 3 other patients, and she knew it was really important that I sat with this lady until her nieces came. And so she took her over looking after my other three patients. She just looked at me and she was like, "It's fine, you stay. You know, you need to do this." And she allowed me to stay with this patient until the nieces came. And I just remember her compassion of understanding why I needed to be by this patient, even though I didn't fully understand it myself. And her understanding of my need to be able to do that. And I remember having a kind of reflection afterwards with her. And I think that sort of real understanding of why we need to do something sometimes are, you know, filtering into my own confusion and my own trauma of being a nurse who's tried to take their own life. And it was just that compassion of my manager meant a huge amount to me. And I think it's how do we look after each other in these situations. And so this is my sort of like kind of thing that I would love us to sort of like do is that acknowledgement, you know, that acknowledgement in that setting that she knew that there was something that I needed to do in kind of my suffering and the patient suffering. That being heard, as being listened to. And then I think that our difficulties and what's going on for us being validated, that we're human too. I think sometimes we feel, you know, or society puts on us that we need to be like, you know, superhuman. And, you know, we're carers, you know, and it can be really hard for us, I think, to think, oh, you know, we're the people that care for people. Not that actually sometimes we need to be cared for. Sometimes we need people to acknowledge our pain, our difficulties, our struggle, you know, and actually we need that. And also, I just think to be valued. You know, one of the most beautiful things that happened when I returned to nursing, so I was actually out of nursing for 12 years. I was sectioned under the Mental Health Act with my nursing uniform in my bag in 2007, and I honestly thought I would never be a nurse again. It was a hard road back, and I think that's important to say. I desperately did want to come back to nursing because there was something very beautiful about the profession, and I thought I would never be a nurse again. And I managed to do my return to nursing course in 2019, and I returned to nursing in 2020, just on the actual day that the World Health Organization declared it a pandemic. And I was like, oh my goodness, what have I done? I started at this point. And I ended up joining the hospice that I still work with now. And the value that the hospice placed on my lived experience in the sense of some of the care that I'm able to give patients meant a huge amount to me. And I often say to people now, not that I was some sort of terrible nurse back in 2007, but I often say that there's a phrase called the wounded healer, that actually in 2007 I was just wounded, and I didn't understand my own wounds to actually be able to care for people. And that whole journey in the mental health system enabled me to grow, understand my own wounds that I can't take away. You can't take away trauma in your life. To understand my own wounds, that meant that I was able to return to nursing and be a wounded healer. That actually in understanding my own, I've been able to have a level understanding of others and know that we just can't fix it. But actually it means a lot when somebody just acknowledges it and sits with you and is willing to listen. And I think we can underestimate the power of that, the power of just somebody being with us, the power of somebody just allowing us to cry. And that's where I really do actually want to thank mental health nurses, because actually it was mental health nurses who taught me that it was okay just to sit with difficult emotions, that sometimes you just had to sit with it. And I remember a mental health nurse saying to me, is there a power in owning the powerlessness of the situation? And I think there was something about that, you know, that the nurses had just said to me, Hannah, I'm so sorry, this is awful. They didn't say anything else. They just said, I'm so sorry, this is awful. And I think that the value then it was put on that learning that I learned from mental health nurses just sitting with me, where they knew that they didn't have an answer. I didn't have an answer. And we just somehow found a way through it. Was really valuable. And I think that valuing of all the things that we have learned in our lives, all of our experiences that mean that we've ended up in that place working with patients, and just to have a value for each other, I just think is so important. And then I think the reality is what helps. And I have this thing where, you know, I think sometimes trusts want to find a way, don't they? You just want to, like, you know, let's do mindfulness, you know, for our staff. Let's do a stress management course. Let's do this. Well, but the reality is, if I've learned anything in the mental health system, actually what helps people is all different. It's actually individual to each of us. Actually, what people need support is with finding what helps them. And I think there's a lot of trial and error. So personally, I do mindfulness, but I hate the breathing ones. I hate thinking about my breathing. I don't like it. But I do mindfulness with a cup of tea, because that one works for me. Or I do mindfulness when I go for a walk. But I also met a lady. I went up to Scotland to do a talk. And I met this, we did a mindfulness for people, and then we talked after how people had found it. And one lady was like, actually, all this reminds me of is COVID, because that's what our trust brought in to help us during COVID. And it completely takes me back to that time. So that's then something really unhelpful for her. It doesn't mean there aren't other things that then are helpful. And I think it's how do we find ways that are helpful for everybody. And I have to say, that's one of the things I love about Doctors in Distress, because Doctors in Distress actually have many different things for different people. In fact, they have a photography group. And I just think that's really important, because actually sometimes we don't always know what helps us until we tried it. But it's individual to all of us. And for me personally, you can see that is actually me. And I am an embroiderer. I was actually an embroiderer before I was a nurse. And this is actually me doing a piece of embroidery. I trained at the Royal School of Needlework, and that to this day has always been something that has really helped me. But interestingly, actually, when I was sectioned under the Mental Health Act, I often wasn't able to embroider, which was quite sad because of the risk of the scissors and the needles. And so I think because of that experience, embroidery has become even more of an important thing in terms of looking after my mental well-being. So that is actually the end of my talk. I think that I'm not sure if these are going to be sent out to you. I kind of hope so. There are references to what I've used. So that's all my references. So what I'm going to do actually is I'm going to stop sharing. It's always fun. And I'm going to try and join you all again. Yeah. And I'm basically going to open it up to questions, to any thoughts, to any kind of thinking that people have, you know, anything where you might even disagree with me. I am very open to any kind of questions about my own story, if you're wanting to know anything about that, just to open up a discussion of things that I've spoken about. So I don't know if anybody wants to kind of, or if there's any questions that are being put in the chat. I'm hoping everybody's still out there. I'm like,
hi Hannah, I thought I'd come back on. It's Carolyn from Doctors in Distress. Thank you for that. I was going to confirm that, yeah, we will be sending out the resources after this to everyone who's registered. So those links you just put up on screen, we'll definitely send them out to everybody. Fatu, I don't know if you were monitoring if there was any questions that came through previously, or if anyone wants to put any questions in.
I am monitoring so far, no question. I do see a hand up from Jordan Trotter. Let me allow them to speak. Jordan, you're on, you can speak.
Hello, can you hear me?
Yes.
Yeah.
I just wanted to say I'm a mental health nursing student. I'm currently in my first year of study at Keele University, and
wow.
I just wanted to say thank you for being so candid. Because mental health is just a really difficult subject to discuss anyway. And you've just been so transparent and open with a bunch of people who you've never met before on a subject that, without obviously professional support, sometimes it goes against every reflex in your body sometimes to share these things. So I really just wanted to say thank you. And I found this webinar extremely useful because we're obviously learning these sorts of things alongside in our lectures. I did notice though during the slideshow that my chat says that the chat is disabled. So there might be people trying to type in the chat, but I haven't got the capability to on my device.
Oh, thank you for sharing that. That's really helpful. Yeah, because I looked at the chat and thought, oh, are there any questions? So it might be that, yeah, that's been a problem for people. Thank you so much for saying that. And I actually, you sort of like opened up something that's actually become very important to me. When I returned to nursing, it was a brave step to be so open. I was with a very supportive team, so it enabled me to be more open. But actually, I think it is important we talk about this. You know, we do hear a lot of trauma and we have our own. And actually, I think the more we talk about it, that understanding and that care for each other. And I just hope that care and support is happening for you as a student as you go into this work. Because the other thing that's really important, I think, to say, and I want to say to you, is it's a really valuable profession. I would not be sitting here today if it wasn't for mental health nurses. And there's many people who wouldn't be, would not have survived things because of all nurses in all the areas that we work in. And I think, sometimes that recognition of actually the work that we do that makes such a difference to people's lives. And I want nurses to stay in the profession because I think there is this struggle. I think it is hard out there. I think we need to have that honesty. But actually, how do we try and support each other? Because actually, from that lived experience perspective, it's so important. Nurses absolutely made a massive difference to me surviving the struggles that I had. And so part of the reason I do this is because of my own need to say thank you to many nurses that I wasn't able to say thank you at the time. And I think that particularly happens in mental health. When you're going through it, you have no capacity to say thank you to anybody because you're just so unwell. And I think that in that particular area of nursing, poor mental health nurses don't get a lot of thanks. But you do an amazing job. So thank you for training to be a mental health nurse.
Thank you for sharing.
Hannah, there are a few comments in the question and answer. I'm not sure if you can see them.
Let me have a look. Is this Bernadette? Thank you so much. Is there any questions?
And also Charlotte has raised her hand and I'm going to allow her to speak.
Oh, okay. Yeah.
Go ahead, Charlotte.
Hi, Charlotte. You're right. It's always this difficulty, isn't it? I think. So we're not able to hear you, unfortunately, Charlotte.
Can you hear me now?
Oh, I can hear you now. Hello.
Okay.
It's horrible, these sort of things, isn't it? It's so stressful.
Okay. Yeah, so I just wanted to pick up on something that you said about vicarious trauma. So I've been a mental health nurse for 20 years, and the past 2.5 of those have been teaching at Keele University as a lecturer. And I think that as mental health nurses, we probably know and readily accept that we experience trauma that's very open and obvious. For example, in the case of violent incidents and things like that, or if we've received a disclosure about abuse. However, I think that we're not very good at recognizing the more subtle forms of trauma, of just sitting with people and listening to people's stories. For 10 years of my career, I worked in the crisis team, and the referral criteria was that everybody was actively suicidal. So hearing those stories day in and day out, multiple times a day, I think we're not always very good as mental health nurses as recognizing that there is an emotional toll that is taken from that, and we need to take care of ourselves. I think that we try to be very brave and think that we have to bounce back all the time.
I would absolutely agree, Charlotte. And one of the things I actually share is that when, as I've shared already, when I started as a nurse, I actually started in HIV. And in HIV, we had really experienced staff like yourself. I was a band 5, had an excellent band 7, had an excellent band 8. And actually, when it came to the psychological difficulties that were happening for our patients, they took over that. They were the ones that talked and heard. And we did have patients who were suicidal in that field. As a band 5, I could do the nice washes. I could just be a nice, kind nurse, not looking at the psychological kind of, but caring for in a caring way. And actually, when it came to the difficult psychological stuff, the band 7s were doing it. Or we actually had amazingly at that time, we actually had a psychiatric nurse who was working on the ward, so we'd refer her over to her. And I think one of the things that I observed myself, or I've really reflected on, is often with mental health nurses, the very thing that you're looking after is that very difficult psychological things. That is it. There isn't the physical. There can be the physical health, but majoritively that is what you're looking after, and that I think takes a real toll, because I look back at that time, and actually that a lot of that was being taken over by more experienced staff. And I think that's really hard. I think that's really tough for mental health nurses, and it is a lot. And I think it's not necessarily recognised by the profession, or even by sometimes the wider profession, of the amount of difficult traumas that you have to hear. And one of the things that I've seen being a palliative care nurse is, when I say I'm a palliative care nurse, I get a lot of sympathy, by the way. It's like, oh, that must be hard working with people who are dying. Now, no, don't get me wrong. It is hard to work with people who are dying. People can be dying before their time. But actually, dying is, sadly, for us as humans, is a normal part of life. Sadly, we all die. And it doesn't mean that it's not difficult, but it is a normal part of life. There are some things that you hear in the mental health system that should never, ever be a normal part of life. And that can be things like sexual abuse that's happened to people when they were children. And that is really difficult, I think, when mental health nurses are hearing that sort of thing. And so I think you're right, Charlotte. I think that there isn't that discussion, and how hard that is. And that actually sometimes, I think, as nurses, sometimes I was explaining it that I was like a runaway train. I was on a track, and I was just, just going high speed, and then I crashed and ended up being sectioned under the Mental Health Act. How do we give chance for nurses sometimes to step into a station for a little bit, to be able to reflect? And I just don't think we give enough of that, actually, for people just to have some time to build up their batteries. I hope that kind of, I don't know, I sort of witted on there, Charlotte, but I don't know whether that was helpful or not. Or
Hannah, we have other hands raised, so I'm going to allow Debbie to talk, and then Corinne. Go ahead, Debbie.
Oh, hello there, Hannah.
Hello, hi.
Hi, yeah. So I'm also privileged enough to be a mental health nurse. Been 22 years in the job. And I just wanted to kind of note the differences on how nursing's changed through the years. So when I first started nursing, when the expectation was is that you were to leave yourself at the door, and I did not pick up yourself back up until you went out of that door of a ward. You nursed your patients. You weren't allowed to, to have any experiences, and that you also had that expectation. You did not take it home. Whatever you did, you were to be a really dreadful nurse if you actually took any of your experiences home, rather than just acknowledging the fact that we're all human.
Yeah, yeah. And actually, that just tells you that that's what you're supposed to do. It doesn't give you the skills to try and, because actually, people need to learn skills to be able to not take it home. And actually, we do take it home because we are human, and it's because we care, and that's a really hard thing to have said. And I think it does. I think it can take us away as feeling like human. I think that is hard.
Absolutely, because I think the build up of that is then it builds the pressure on us and that expectation that I should be able to do these things. Therefore, I'm either not good at what I do, or we become detached and we don't be the best of ourselves that we could be for our patients either.
Yeah, I can completely agree. And I think it is hard. I think there is this pressure that we've got to be superhuman, but actually being a patient on the other side, do you know what? It was so nice when I had a nurse who was just honest and said, I struggle with that as well, Hannah. And I'm like, oh, thank you. Because actually that humanness can actually make you feel better as a patient, because then you don't feel like so, because for me, it was really hard. It was quite hard to be cared for by nurses because I'd been a nurse, and then I felt like a real failure, and actually to have nurses who were really understanding and, really caring in that and really very human. And I remember having this one nurse, and he was lovely, like yourself, worked as a nurse for many, many, many years. And he said, Hannah, even to this day, he said, I have to look after my little, he held his hands like this. And he said, I have to hold my childhood self, and he said, I think you need to do that as well. And he said, I always have to hold my childhood self, because he said, I have to protect it because it's really fragile. And I just remember that's just real honesty of what he had to do, and actually really connecting to that. And that just real conversation that I had with him that was just very human. And that meant a lot to me as a patient, him sharing that with me. He wasn't sharing about his life or where he lived or but he was sharing something really core that had helped him. And I think we can forget that sometimes, that can actually really help patients as well as help ourselves, that actually ultimately we're all humans trying to help each other.
Absolutely. So I hope my colleague who's just starting her training, they're the experiences that before we've learned that actually we're allowed to be us as well. So I hope that our colleagues on here as well, probably in very different degrees of their trainings, will have different experiences as well, but it's allowed now.
Yes, and I think it's important, and I'm really glad that's what is being taught, because it can give things to patients that we don't even realise. So thank you, Debbie.
I'm going to allow Corinne to talk, and then Alison, and there's a question in the chat. Go ahead, Corinne.
Hi, I just wanted to say thank you, really. I have put that in the Q&A before the chat was opened. I put a couple of comments, but I think you've already said something. I think it was Charlotte was speaking when she said about mental health nurses. So I'm a mental health nurse by background. I'm now in education, but after 21 years in mental health, I felt I'd sort of had enough. I'd kind of had enough. And that was actually, obviously no one knew it was coming. That was before COVID. And I'm sure that probably would have just about finished me off, really, because I felt I had taken on lots of things over the years. And I think and I think you've already said this now, that one of the things I think is those sort of stories we hear as mental health nurses. But what I do think is that this conversation is so vital, and I've said thank you for talking about this, because I feel it's not just mental health nurses. I used to work with community matrons and district nurses, people that go into people's homes and you see the best of people, but you sometimes really see the worst of people as well. You know, the way they might treat family members or spouses or children. And I just think this would be such an important conversation. I hope there are other people other than just mental health nurses on the call. I'm sure there is, because I think this is really important, and I bet there are pockets where it's really well recognised. I think, like you say, maybe in palliative care, maybe A&E, you'd hope to some degree, or that also that it's okay for people to have a certain lifespan in that certain sort of job span in that environment before they need to move elsewhere. And we talk to people. I mainly teach on postgraduate, but I do still do some mental health undergraduate teaching. We definitely talk to people about looking after themselves and finding time and space. But I also think with postgraduate teaching, often teaching people who are really senior and experienced, and they're really great at helping other people with this, but not always so good at looking after themselves with this, and or sort of beating themselves up about a move away from more acute crisis type services, or, you know, a move into something managerial or strategic. And yeah, I think there's probably more to be said about this and across a wider thing. But it's so the conversation started.
And I think it is. I think it is the conversation, isn't it? You know, and I think we do. And I think sometimes we need help from other people, because we can, as nurses, we can really beat each other. You know, we can really beat ourselves up. You know, and I think that it's that thing of, actually, there's a lot of this thing about, you know, sort of, you know, like resilience training and, you know, stress training, and there's lots of things around this, and sort of ownership on you. But actually, one of the things I want to say is, how do we be resilient teams? How do we look after each other? Because actually there are times, you know, however much we want to think that, you know, all of these things, that actually sometimes lots of things come into place from our own personal lives. You know, the fact that we might have a few patients that have really told stories that have really really hit us hard. How's the team resilient, that we look after each other? Because I think that gets lost sometimes. But I think you're absolutely right. I think with community as well, you know, with all nursing, we all see trauma, and sometimes it's the more obvious trauma that actually we can manage. It's the stuff that's not so obvious, you know, when we, you know, people do go into the community and it's very, you know, there's a lot of deprivation, and there's a lot of, you know, people on their own and they're not look after themselves, and a lot of, you know, self-neglect. Those are the sort of things that can be really hard and hit us really hard. And you know, where do we go? Where do we talk about it? Where do we get support? And there is this sort of thing of, we just need to just get on, and you know. And actually, like you said, I think it was really good what you said, you know, it can then get to a point where actually that burnout, what we know is then that burnout. Thank you for sharing. Thank you, all of you, for sharing.
Hannah, before we wrap up, we're just a few minutes away. I'll just let Alison talk, but I want to also remind all the participants that we do have feedback surveys that we will share with you all via email along with this recording. And it's very important if we can get all the feedbacks so that we can continue offering these free sessions. Thank you. So I'll just let Alison speak, and then we can wrap up.
My light's gone off. I'm at Kingston University and I don't know how to put the light back on. You're going to have me in the dark. That's fun, isn't it?
Hi, Hannah. Hi, everyone. I'm not sure if people are able to hear me. Hopefully you can. Thank you so much again. I know we come into contact with each other very, very often in our work, and it was just inspiring and very moving as always. But I kind of just wanted to agree with everything that's been said already. Again, you're preaching to the converted, because as you know, I'm a mental health nurse, and for 26 years now, and I really agree that there was very much, there's been very much a culture of you know, leaving your life at the door and then not taking and carrying that sort of those experiences and traumas home with you, but without actually acknowledging that you need the skills to do that, and you need to be supported to be able to do that. I mean, I was really lucky that I was in a relationship with somebody who did the same job that I did, and had an understanding. We both had an understanding of some of the experiences we probably had. I had a really supportive ward manager and ward psychologist